Hey everyone, in this video we are going to discuss about the chemotherapeutic drugs. Some of you were asking me to make the videos on these drugs as papers are coming up. So I'm making the videos on it and I'm glad that these videos are helpful for you. Okay, so in this video, we are going to discuss about the principles of the antimicrobial therapy, and we are going to discuss it from the Lippincott because this is written in the Lippincott only, and then all the drugs that are the chemotherapeutic drugs. So we are going to discuss them from the Katzen. Okay. Basically, we are discussing these principles first because that would give you a better understanding of what is the principle of these drugs, how the resistance is developed, and many other things about the drugs. So that would give you a better know-how and you can say a general concepts about the antimicrobial drugs. So in this video, we will be discussing about the selection of the antimicrobial agents. Then we have some other topics like the route of administration, determinants of the rational dosing, chemotherapeutic spectra. We will also discuss the combinations and drug resistance, the prophylactic use, and the complications in the sites. Okay, so these are going to be the topics which we are going to discuss in this video. Okay, so let's get started. Okay, so let us first start with the overview. So basically, how these drugs work. So this antimicrobial therapy, it basically targets that specific property of the microorganism that is not, you can say, similar to us, that is not common to us human beings. Okay, so basically, they take advantage of the biochemical differences that exist between the microorganisms and the human beings. It means that only those properties that are unique to microorganisms, so they are going to target those properties, so they are not going to harm us. Okay, so antimicrobial therapy, these are selective in nature, they have a selective toxicity. It means that they would have such property that is only going to target or only going to you can say injure or kill the invading microorganism without damaging our cells. And as this word is telling you that anti means against and microbial means microorganisms, so this therapy would be against the microorganisms. Okay, so let's move ahead. We have selection of the antimicrobial agent. So on what basis we are going to select our antimicrobial agent that we would be prescribing to the patient. So these are some you can say the points. So, before selecting any antimicrobial agent, we should have the knowledge about the organism that has caused infection, then the susceptibility of that organism to the particular agent, it means the antimicrobial agent. Then, what is the site of infection? It means what is that area where the organism has done the infection. Then, the patient factors. Then, we have the safety efficacy of the agent. Then, the cost of the therapy. So, these are all the points which we will be discussing later on in more details. Okay, we will discuss it one by one. And mostly, what happens is that the patient come to us for the empiric therapy. Okay, what is empiric therapy? It is basically an immediate therapy that we would be prescribing to the patient without the, you can say, the bacterial identification and the susceptibility testing. It means that we are basically prescribing the drugs with the best of our knowledge before we get to know what bacteria has caused infection or the organism is susceptible to which drugs. Okay, so this is what is the empiric therapy. Now let's discuss these points one by one. So first of all, we have identification of the infecting organism. Okay, so this step is very important. Identification is very much important before initiating the treatment. So how you're going to identify the organism? So these can be identified like for example, we can perform the gram staining. So this would help us identifying the presence and the morphologic features of the microorganism that are present in the body fluid. Those in the body fluids that are normally sterile. For example, we have the blood, CSF, in which you know that normally the microorganisms are not present. So we can detect their presence in these fluids. Okay, and we have other fluids like you can say the pleural fluid, synovial fluid, and the peritoneal fluid, then the urine. Okay, and we have some other tests as well from which we can identify the microorganisms, like with definitive identification. For these purposes, we have the laboratory techniques such as detection of the microbial antigens, DNA or the RNA, or the inflammatory or the host immune response to the microorganisms. So these techniques are required for the definitive identification. And as you can see in this figure as well, so these are some laboratory techniques that are useful for the diagnosis of microbial diseases. And here you can see the five of them. And the newer techniques can be PCR or the MALDI-TOF, which is the matrix assisted laser desorption or the ionization time of light. So these techniques provide the accurate, rapid, and the cost effective identification of infecting organisms. Okay, then we have the empiric antimicrobial therapy. So ideally we know that when we start the antimicrobial therapy, when we know that which organism has caused an infection, it means when the organism has been identified, and when we get to know that the organism is susceptible to this drug or it is resistant to this drug. So when all of these things are known, then we prescribe the patient the appropriate therapy, antimicrobial therapy. So but what would happen if the patient is critical? Okay, so if the patient is in the critical condition, so definitely that delay, it could be fatal for him. So in that case, we are going to prescribe the empiric therapy. So that immediate empiric therapy is very much important to the critical patient. Now we are going to discuss the timing and selecting a drug. Now, the first is the timing. So, this timing would tell you that when you have to start this empiric therapy. So, for example, if the patient is acutely ill, so in the acutely ill patient, and for example, if the origin is also not known, for example, in the case of the neutropenic patient, who is at the risk for the infections, that is due to the decrease in the neutrophils, or if a person is suffering with the meningitis, which is, it is a acute inflammation of the membranes that are covering the brain and spinal cord. So in both of these cases, the patient would require the immediate treatment. But yes, if it is possible, then you can provide the treatment after the laboratory analysis has come. But yes, you shouldn't wait for more time, okay, because that would be fatal, as I've told you. So the culture and sensitivity results takes long time, so you should start the empiric therapy before that. Then we have selecting a drug. Okay, so how you're going to select a drug if you don't know what organism has caused an infection, or even you don't know about what that organism is sensitive to or resistant to. So for selecting a drug, you would look for these things. Okay, that would definitely be influenced by the site of infection, by the patient history, by the previous infections, or the age. So these are all the things that you would consider. Okay, so age, or the recent travel history, or the recent antimicrobial therapy, or immune status, or whether the infection was hospital acquired or the community acquired, then the local susceptibility data. So all of these things will be considered before selecting a drug. Then the broader spectrum drugs are often prescribed when the infection is because of the polymicrobial. If it is polymicrobial, it means if it is caused by multiple organisms. Okay, then the association, that is between between the disease and the microorganism, that would be recognized. Okay, for example, if a patient is newborn, and for example, if the clinical scenario is that the gram positive cocci are present in the spinal fluid of the newborn baby, so definitely what you would think, so it is most likely because of the strep ehrlichia. And as you know that strep ehrlichia is sensitive to penicillin G. So what would be your definitive treatment for it? So definitely you are going to treat the patient with the penicillin G. And for example, if the clinical scenario is same, and if instead of a newborn, if a old person comes to you, okay, if the person is 40 years old, then you would say that it is most likely because of the strep pneumoniae. So this infection is because of the strep pneumoniae, and as the strep pneumoniae is resistant to penicillin G, so you are going to treat the patient with the cephalosporins, or the, you can say, the vancomycin. Okay, so these would be the drugs. So this is how you would select a drug. Then we have the C part, that is determination of the antimicrobial susceptibility. Okay, so if you know that what that organism is susceptible to, so that would provide you a guidance in the selection of the antimicrobial therapy. And okay, in some cases, some species they usually have the predictable susceptibility patterns. Some have unpredictable susceptibility patterns, like we can see here. The streptococcus pyogenes and Neisseria meningitidis, they usually have the predictable susceptibility patterns. It means that most of the times we know that what they are sensitive to, because their susceptibility criteria do not change. Okay, then we do have some other species as well, that those whose susceptibility changes from time to time. For example, we can see this example in the case of gram-negative bacilli, enterococci, staphylococci species. Okay, so in all these species, they show the unpredictable susceptibility pattern. So for them, what we have to do, we have to perform the susceptibility testing in order to determine the appropriate antimicrobial therapy. Okay, so we can determine these things by MIC and the MBC, which is minimum inhibitory concentration and the minimum bactericidal concentration. Okay, now let us see what is this MIC, what is MBC, and what is the difference between the bacteriostatic and the bactericidal drugs. Okay, so in the past, what it was thought? So it was thought that the bacteriostatic drugs are those that can only arrest the growth and replication of the bacteria. That is, they can only stop the growth of the bacteria at the drug levels that are achievable in the patient. Whereas the bactericidal drugs, they were considered as cidal means to kill. Okay, so these drugs, they were thought to be able to effectively kill the 99 or 99.9 or more than 99.9% of the bacterial colony within 18 to 24 hours of incubation. But now this seems to be too simplistic. Why? Because some bacteriostatic drugs, they can also effectively kill the microorganisms. Okay, not only they can inhibit the growth, but they can also kill the microorganisms. But some microorganisms, for example, we have an example of the linezolid. Linezolid is bacteriostatic drug. Okay, and it is bacteriostatic against the staphylococcus aureus and the enterococci. But this bacteriostatic drug can be bactericidal against the most strains of strep pneumoniae. So see that the bacteriostatic drug is bacteriostatic against some species, and it is also bactericidal against some species. So it means that this bacteriostatic can work as a bactericidal against some organisms. So so that particular definition that was believed to be true in the past, so it is not more realistic. That is why that definition is not much accepted. Okay, now let us see what is MIC and what is MBC. So the MIC is basically the minimum inhibitory concentration. It means the minimum concentration or the lowest antimicrobial concentration that can prevent the growth of the organism after 24 hours of the incubation. Okay, and this is basically a quantitative measure of the susceptibility of microorganism. And as the time and the labor requirements are not much, so this is most often done. So this is the most common approach that is used by the clinical laboratories. Then we have the MBC. So what is MBC? It is a minimum bactericidal concentration. The name is telling you that it is the lowest concentration or the minimum concentration of the antimicrobial agent that can kill the 99.9% of the bacterial colony or the colony count after the overnight broth dilution incubation. And this is rarely determined. Why rarely determined? Because of the time and the labor requirements. Okay, then we have the effect of the site of infection on the therapy.